So I think the takeaways that we have learned in the metastatic setting clearly can be applied, at least the principles, in the early stage setting as well. And one of the pivotal studies, the MA31 trial, showed that taxanes and trastuzumab was better than taxanes and lapatinib, and we saw something very similar in the neoadjuvant and adjuvant setting. So it shows that we can translate some of these evidence into the early breast cancer setting as well. Now, what we current treatment for early breast cancer and in the both neoadjuvant setting is, we give chemotherapy plus anti-HER2 treatments. And now FDA has approved pertuzumab and between 3 to 6 cycles in the neoadjuvant setting. So that's been incorporated in the US. And we also have learned that more recently that in certain patients we can de-escalate chemotherapy by giving weekly paclitaxel and trastuzumab therapy. And I think so right now where we sit in a neoadjuvant setting is really trying to balance which patients can we de-escalate therapy for and which patients do we need to give all the treatments that we have, including chemotherapy, trastuzumab, and pertuzumab. And I think that's going to be the next 5 years, is trying to be better able to risk stratify individuals where some patients may just require minimal chemotherapy, whether it's weekly paclitaxel, and maybe in the future, if the studies are confirmatory, maybe even TDM1. On the other hand, we need some patients where we need to give the anthracyclines, the taxanes, the pertuzumab, and the trastuzumabs, and maybe other novel therapies. So I think that the issue of how to de-escalate therapy versus how to escalate treatment for certain patients is going to be critical.